at the National University of Singapore, as well as a senior consultant in infectious diseases. Our topic today is very relevant and important to us. I just want to touch on a couple topics before I introduce our speakers. Teaching hospitals are critical training sites for medical students. They've been so for at least 100 years. They expose the students to a broad mix of patients and diseases and provides exposure for them to practicing physicians as teachers and introduces them to the requirements of apprenticing, the apprenticeship that will come during their postgraduate training. Medical education has been compromised, obviously, by COVID-19 that we've all experienced due to limited travel, decreased elective procedures, limited exposure to rotations that weren't absolutely required, and delayed or even canceled exams. So it's really very relevant to our speakers today. We're going, in today's sessions, we'll hear about how AAHCI's members in Indonesia, the Philippines, Uganda, and Qatar are adapting to continuing medical education in this era and managing the critical relationships. Before we begin, let me introduce all of our highly distinguished panelists, and then we'll get to their topics. Professor Damali Nakanjako is Dean. She's Professor of Medicine and Dean of the School of Medicine at Makerere University College of Health Sciences in Kampala, Uganda. She has over 18 years experience in infectious disease care, research, and training. She's Scientific Director of the Translational Laboratory at Makerere University's Infectious Disease Institute, where she leads a translational immunology research group. She's co-director of the university's Uganda Virus Research Institute, Infection and Immunology Program to build Africa's capacity for scientific leadership in infection and immunity research. She's the winner of the 4th annual Merle A. Sandy Health Leadership Award in 2013, a very prestigious award in recognition of her contributions toward leadership in healthcare in Africa. Her research group focuses on chronic inflammation and its complications among HIV-infected adults, on lifelong antiretroviral therapy and HIV cure research in sub-Saharan Africa. She's mentored over 50 upcoming scientists at master's, doctoral, and postdoctoral level to build the next generation of scientists that will combat current and future challenges to global health in Africa and worldwide. Dr. Ibrahim Janahi is Chair of Medical Education, Designated Institutional Officer, and the Division Chief of Pulmonology at Sidra Medicine. In addition to his current responsibilities at Sidra Medicine, Professor Janahi is a Professor of Clinical Pediatrics at the Weill Cornell Medicine in Qatar. He's also founder and president of Gulf Society of Pediatric Respirology and a founding member of the Arabic Pediatric Pulmonology Association. Completed his pediatric residency at the University of Illinois College of Medicine in Peoria, Illinois in '97, after which he started his postdoctoral fellowship in pediatric pulmonology at Baylor College of Medicine in Houston, Texas. Professor Mohammed Miftahussarer is currently the head of Helicobacter pylori and microbiota study group in the Institute Tropical Disease, Universitas Airlangga. Apart from being the head of the study group, he holds the chair of vice rector for internationalization, digitalization, and information of Universitas Airlangga. After chairing the Center for Journal Development and Scientific Publications at the university for 3 years. He earned a specialist education in internal medicine from Airlangga in 2011, obtained his PhD in medical sciences from the Oita University Japan facility in 2016, and gained his postdoctoral gastroenterology training from Baylor College of Medicine, also in the United States in 2017. And Professor Charlotte Cheong, who was recently elected academician of the National Academy of Sciences and Technology. She's currently Dean of the University of Philippines College of Medicine, a research professor at the National Institutes of Health and University of Philippines, Manila, and a clinical professor in the Department of Otolaryngology at Philippine General Hospital. She's a highly trained otolaryngologist with training at the University Philippines General Hospital, Harvard, and the University of Toronto, where she pioneered cochlear implantation in the Philippines and advocated for universal newborn hearing screening and early intervention act. She was past director of the Philippine National Ear Institute and the Newborn Hearing Screening Center, and led an interdisciplinary Hearing for Life research program and the National Cochlear Implant Program. She's past president of the Philippine Society of Otolaryngology, Head and Neck Surgery, past president of the Philippine Academy of Neuro-Otology, Otology and Related Sciences, and general secretary and founding general secretary of the ASEAN Academy of Neuro-Otology, Otology, and Audiology. We have a very distinguished panel, and each panelist will be asked to present for up to 10 minutes. After, we'll have some facilitated question and answer with myself as your facilitator. You can type in your questions in the question and answer toolbox there at the bottom of your screen when it becomes available in the Zoom toolbar, and we'll deliver your questions to the panelists. Professor Nakanjako, please put up your slides, and over to you.
Thank you for those kind introductions. Let me share my screen. Okay, thank you very much for inviting me to this meeting. I've already been introduced, and I'm happy to present our experience in Uganda during the COVID pandemic. Thank you very much for this conference, which is really applicable to the current situation. And so I'll talk about how we have been managing the relationships between universities and teaching hospitals during this COVID era at Prairie University, at our School of Medicine. So we have really had collaborative efforts in COVID-19 clinical care, and this picture shows Mulago Hospital, which is our national referral and teaching hospital. So this is our major partner in training, although we have other training sites that are also under the Mulago Teaching Hospital. So during this time, we have had to repurpose teaching units and faculty to support the COVID-19 response, because these have been the core responding clinicians and researchers during this time. So we have played a major role both at the hospital level and at national level. We have our pulmonary unit, for example, at the Lung Institute, has been the major unit that is running the intensive care unit and all the pulmonary research and complications in the HIV, in the COVID-19 pandemic. And in the intensive care unit, our anesthesiologists and critical care physicians, our teachers have been very instrumental, and they are involved in training and expanding the use of ventilators. So this has been a very useful collaboration. And of course, our infectious disease faculty have supported case management. They are the people that have been at the forefront of managing the cases. We, as a university and all our teaching units, we have made major contributions to the national COVID response. Our Infectious Disease Institute at Makerere University College of Health Sciences has led this response through the Global Health Security Program. These are pictures of our institute members supporting the COVID-19 activities. They have supported laboratory strengthening, diagnostics, and training and use of the personal protective equipment, as well as training on implementation of the standard operating procedures that have been reviewed both at unit level and at national level. We've also made use of these of our public-private partnerships in the COVID response. This picture shows members of Cairo Bank. This is a bank in Uganda who supported donation of medical protective equipment to support service delivery and teaching activities. So these together, we have members of the School of Medicine in this picture, and we have the Director General for Health Services in this picture, together with the Executive Director of Cairo Bank. So these partnerships have helped to support financing for items like protective equipment, which are much needed and are really consumables that are at a cost that we probably would not have been able to afford completely as a school. I've also put MTN Uganda. This is a telecom company that has also supported us in getting this equipment to support service delivery and to protect students and faculty. We have also led in setting up online training for health workers and faculty on infection prevention and control measures. These are online. This is an example of an online course that has been developed, and it is taken by all our faculty and students as an online course to support their protection and protection of others. We have also transitioned to online learning. We are having more clinical case discussions, clinical rounds, and webinars online. Although we continue with physical clinical work in small groups, of course, according to the guidelines that are given. And our faculty have been trained on online pedagogy to enhance their capacity to offer most of the courses that can be offered online. We have implemented our guidelines on online thesis defense, so masters and PhD defenses are continuing to go on, and our blended approaches have actually shown that there's improved attendance and efficiency of time. People don't have to spend a lot of time in traffic to attend these meetings. So inadvertently, we've had very high attendance of these meetings. So we continue to enhance our blended learning facilities. We have learned a lot in this and seen many beneficial effects in this area. Teaching, learning, and research during the COVID-19. Again, this has called for a lot of collaboration and innovation for research activities to continue following the COVID-19 prevention SOPs, because actually many of these research activities are also related to COVID-19 and the co-infections. And online research and ethics committee activities have had to continue, so all our research and ethics committees have quickly transitioned to reviewing and executing their duties online, having online meetings and clinical care activities so that they can remain operational. Units are meeting online, departments are meeting online to reduce physical contact, but continue with their operational activities. And we've had to work on timetabling to make sure that both clinical service delivery for COVID and non-COVID illnesses is managed very well. Our costs have increased to cater for the increased demand of bandwidth for these activities, but also for the personal protective equipment. And our infrastructure, we have, academics have contributed to the COVID response in terms of one, infrastructure. So all the laboratories for immunology, bioinformatics have been involved in phylogenetics and modeling of this epidemic. We have the Uganda Medical Informatics Center, the African Center for Excellence in Bioinformatics at our Infectious Disease Institute. And we have also led laboratory training efforts to expand national response, both in country and at the border points. So all these are our pool of scientists that have been repurposed to generate national data on the COVID-19 pandemic. Funding has been awarded to our faculty, so our faculty have contributed in applying for competitive funding to support COVID research. The Uganda government has funded our faculty to do vaccine studies in COVID. The African Research University Association, ARUA, has also funded capacity development for preclinical studies in COVID vaccine-related research. We have faculty that have won funding from the African Academy of Sciences for various COVID-related activities. So this has greatly supported research in this area. And we have also had our university provide a research fund to support COVID research, and these are some of the researches that have been done. Digital follow-up of HIV patients during the pandemic so that to reduce overcrowding of the clinics, looking at SARS-CoV-2 transmission during pregnancy and delivery, pulling samples for expert testing. Our university has also made a low-cost ventilator which can be used in the different parts of the country, and various innovations on hand washing models to increase access. And we have also had a number of clinical trials that are ongoing, looking at convalescence plasma as a mode of care, looking at hydroxychloroquine, all this to support the clinical care in collaboration with the teaching hospital. So we've also had our teams at the university lead the national response through work to understand pathogenesis and clinical characterization of the disease, diagnosis and training, community engagement with policymakers and the wider community. Many of our faculty have gone to TV and radio programs to disseminate information about the control of disease. Many are frontline health workers for both COVID and non-COVID services so that healthcare can continue. And many of our faculty have been appointed to advisory roles to advise the national task forces and the Ministry of Health. So, and this is just an example of a few of publications that have come out of Uganda during this time, and our faculty have contributed to generation of this data on the pandemic. So what can I say about the relationship during this this pandemic? I would say that the relationship is collaboration, collaboration, and collaboration. And I would like to really appreciate all our collaborators and to acknowledge them and say that together we can make a good response to the COVID pandemic. Thank you very much.
Thank you, Professor Nakanjako. Impressive body of work and congratulations. We will have questions. If you'd be so kind as to join us at the moderated session at the end of our program, we would be most grateful. And Professor Janahi, if you would, over to you. If you could share your slides.
Thank you so much, and good morning, good evening to everybody. I don't have slides. I'm just going to sit here and
Excellent.
talk. How about that?
That sounds good.
I decided not to put anything in slides and kind of go over what we are doing over here in Qatar in response to COVID, and translate that into how our academic health system at Sidra responded to that in relationship to the academic activities and teaching of the students and the graduate students and residents and fellows. So welcome everybody to this webinar. And in general, for those who do not know Qatar much, Qatar is a very tiny country, small, and the health system here is pretty much unified. It's singular. It's all managed under the Ministry of Public Health when it comes to public health issues. Our hospital is the main tertiary pediatric hospital. We do women's and children care, mainly pediatric. There's a little bit of OB that happens in this building as well. So it's a specialty teaching hospital and academic health system. So we have a very robust research arm to our activities, in addition to education as well. We are the primary affiliate of Weill Cornell Medical College, as well as Qatar University with its medical college, as well as College of Pharmacy and College of Allied Health. In addition to that, we are also affiliated with University of Calgary, Qatar campus for the nursing school. So we get nursing students as well as medical and allied health students to do their clinical rotations and clerkships here at Sidra. Now, we always had students, different types of students, as I mentioned, in addition to having a very rather large pediatric residency and a cadre of a number of pediatric and women's fellowships, in addition to some other fellowships, including child psychiatry, women's psychiatry, pediatric radiology, and many surgical programs under pediatric auspice as well. So in general, this place is a very active teaching hospital. The postgraduate education is modeled against North American model, so it is AAHCI accredited programs when it comes to the residency, as well as many of our fellowships. So therefore, at any given time, you have many learners around the hospital. Now, with COVID coming on board, that obviously brings a huge challenge to any academic health system, especially when you have to maintain all the teaching activities and all the academic activities in the midst of social distancing, midst of trying to avoid any co-infection and so on and so forth. So before I dwell into the details of how Sidra Medicine maintained its academic activities while observing the guidelines and the strict guidelines of the Ministry of Public Health when it comes to COVID-19, let me just rewind back a little bit and go over the measures that Qatar has taken in order to fight this pandemic. So immediately, right after the WHO announced that this is a pandemic, the National Emergency Response Center was activated, and the National Emergency Response Center is chaired by the Prime Minister, and it's co-chaired by the Minister of Health. There was a couple of rather executive committees that were formed, and they oversee all the measures. Those executive committees include membership from the different stakeholders, the Ministry of Health, Ministry of Commerce, Ministry of Interior, and some other ministries as well. They're all represented, and all the decisions around measures are all taken with consensus around with all these different stakeholders having their input into this these recommendations, these guidelines, and some of the guidelines translated into new laws and new regulations that the government implemented on a compulsory basis, like things like mandatory testing, mandatory isolation, prosecution of people who break quarantine and so on. Those measures were rather strict, and that has translated into very low level of transmission in Qatar itself. Any pocket of COVID-19 that was discovered, they were immediately quarantined by the different authorities that subscribe to these governing bodies. I remember earlier on in the pandemic, there was a pocket amongst the single male labor camps that was identified, and that whole area was sort of isolated, and to make sure that the humanistic part is taken care of, all the measures that are needed, all the things that are needed for these people to live a quote unquote normal life were provided immediately to the pocket that was isolated, and so on. So I don't want to spend too much time talking about the general measures, but there was, like many other places around us, especially in the GCC countries here, there was very robust activity that sort of considered the health measure at one side, but also the economic impact and the mixture of trying to avoid a massive economic repercussion, and the balance between that and not getting into the sort of open economy is taken over and the health is going down. So that the mixture was, I think the balance was struck in a very nice way. So far, so good, I would say. Now back to our center here at Sidra. Sidra has responded. Obviously, we also subscribe to the network of the healthcare facilities that is managed centrally by the, when it comes to COVID, managed centrally by the Ministry of Public Health. So we were designated, Sidra was designated as COVID-free zone or COVID-free hospital. So any kid or any patient who has a positive test will not be admitted to Sidra. Any person who is positive, he will not be allowed in Sidra building. All the gates were sort of guarded, monitored for basically temperature testing, and we had this phone application that you have to always show as, and it continues like that. So if you are positive, you're out. The students now, we come to the students. So there, we here at Sidra Medical Education Office that I run, the Medical Education Office, the Department of Medical Education oversees all the teaching activities, all the academic activities, excluding research. Research is under research premise, but any education is under this department. And this department managed and worked with the different stakeholders, medical schools and other schools, to basically change some of their curricula into online curricula. So anything that was classroom went all the way, right away, into the electronic platform, Zooms or WebExes and so on. Anything that was bedside, we tried to manage the number, the distance, the PPEs, to make sure that the students and the learners are not exposed or they are not threatened. They are not either threatened or threatening patients or others with the COVID-19 or any other infectious diseases. So PPEs were all provided. The number of people who are allowed in a given space or in a given setting was reduced, obviously, to maintain the social distance of 1.5 meters at least. The third thing is that anything that could be done without being physically in the hospital was changed into online. That has, early on, initially it was very tight to make sure that we have a good grip and control over this. And as the numbers started to stabilize and start going, number of COVID patients start going down in the country, we started to loosen up some of these measures, guided by the general national guidelines. Obviously, we did not go de novo and you know, took our own decisions. These were all guided by what the national guidelines is telling us. So there was very coordinated measures of scaling up or scaling down the measures depending on the guidelines we get from the Central Command Committee. So as it stands now, we've wound down majority of the measures. We are still not back to pre-COVID, obviously, but thanks goodness we have not observed the second wave yet, although that is not unanticipated. But we feel the command center feels that is less likely that we're going to get a bad second or third wave. For many reasons that there are many scientific reasons that this is not the forum to talk about why, but anyways, that's what they're thinking, and therefore we are still doing something like almost 70% back to normal. Students are rotating in the hospital physically. They are still keeping the social distance, obviously. PPEs are mandatory. The curricula are implemented rather robustly. The schools have graduated some of their, you know, whoever needed to be graduating, they graduated. The graduation parties were all online, but people graduated. Residency started July 1st. There was some delay in getting onboarding residents because of, again, we're in the midst of the pandemic at that point. Therefore, most of the startup rotations were all those soft, quote unquote, soft rotations that they didn't need to be physically in the hospital, and so on. So these curricula were modified, were switched back and forth in collaboration with our and consultation with our accreditors in the US. So they were, you know, our AAHCI, I was always in consultation with, we were in consultation with them to make sure that we are not deviating from the requirements. But there's the good news, obviously, is there's enough flexibility in the AAHCI system, the accreditation measure bodies that would allow some tweaking of the curricula, some tweaking of the way we do the business of training and education, that would allow not losing the whole track and modifying it to satisfy the accreditation requirement, the training requirement, but also avoiding risking patients' health and people's health. So I think I'll stop there. Just kind of, I wanted just to kind of put some highlights on some of the measures, and I'm looking forward to a fruitful discussion upon the end of this session.
Thank you very much. That was a very nice, understandable overview of what's going on. Gives me a great appreciation of it. So we very much appreciate that, and we will have some robust discussion, I believe, at the end. And it allows me to ask Dr. Miftah Husserer to jump in.
Hello, Professor David Allen. Thank you very much. Good morning, all, or good afternoon, probably afternoon or evening, and a very warm greeting for all of you at the AAHCI Regional Roundtable International Collaborations, Contributions, and Barriers in Time of COVID-19. It is with great pleasure for Universitas Airlangga to be able to participate in this roundtable together with the other participants. Let me share my slide. Could you see Professor Allen?
Yes, I do.
Yes, okay, thank you very much. So today I will deliver 3 important points before I share our experience on the topic of international collaborations, contribution as barrier, and one is on our profile and how we play a role as a higher education in responding to social determinants of health in the era of Industrial Revolution 4.0. And the second one is about our internationalization program and the synergy of our academic activities. And the last one is about barriers challenge of UNER in the force to face challenge, emphasize on the role of our academic health science institute. As the comprehensive university, Universitas Airlangga is comprised of 15 faculties and 1 school with a total of 170 study programs across different campuses. Our study programs range from medical and health science, life science, technological science, and as well as social and humanities science. With 39,197 students, Universitas Airlangga is supported with 1,930 lecturers per September 2020 and 2,085 administrative staff, and we are truly committed to increasing their well-being. Ladies and gentlemen, to ensure our administration system meets the standard, we have established the Airlangga Integrated Management System, or also known as AIMS. Our quality assurance board monitor to the results and performance of all work units through establishing an up-to-date procedure guidelines in all areas. Most of the study programs in Universitas Airlangga are accredited by our national accreditation body. However, Universitas Airlangga always encourage its faculties to always improve the quality of education by conducting international accreditation as well. And we have several numbers of international accreditation already, such as IWA, Malcolm Baldrige, and also ISO. Based on KIES World University Ranking 2020 among esteemed university in the world, UNER is ranked from 521 to 530 worldwide and 124 in Asia. Whereas in Indonesia, UNER is considered as number 4. In addition to our subject, the medicine and also business and management system are ranked in 551 to 600 and 451 to 500 respectively in the world. There are a reflection of our continuous endeavor to strive for quality improvement. Moreover, for time higher education, impact ranking, UNER has been ranked in 301 and until to 400 in the world. With regard to supporting sustainability and green campus, UNER aims to improve itself in ensure green practice within campus as well as within all aspects of campus life. And at the moment, UNER is ranked 255 Universitas Indonesia's green matrix. I would like to introduce the Academic Health Science Institute as a model of interprofessional education as services of Universitas Airlangga, and academic health science actually is an organizational network that consists of medical, health faculties, and also teaching hospital, research institute, private sectors, and also local government. And AAHCI become part of health education system integrating to provide the best health outcomes to society through health educations and transnational research that will impact the continuous quality improvement for healthcare. With the help of the agencies, institution, organization, and donors, Universitas Airlangga Alumni Association also present Universitas Airlangga Floating Hospital. And as addition to services for medical care, Satya Airlangga and the name of Universitas Airlangga Floating Hospital was initiated by college from our Faculty of Medicine and its alumni association to help and complement health services from the government. And recently, Universitas Airlangga has a vast network of partnership of both national and international level as well as global consortiums. And on international level, our active partnership are comprised of more than 200 partnerships globally. For each global network, Universitas Airlangga is involved in several collaborations, and the partnership take many forms such as human resource recruitment, joint research, student lecturer, and staff exchange, double degree, and many other forms of mutual collaborations. And Universitas Airlangga also initiate World University Association for Community Development, focusing on global community outreach program and initiatives. We have also international hubs, including American Corner, AAHCI Bench Corner, Pakistan Region Corner, Taiwan Education Center, and also Center for Indonesian Studies in Asia University Taiwan, and Indonesian Corner in Prince Songla University. And some to be mentioned, UNER has sent around 1,000 students overseas, and also to our global partner. And for student mobility, we have receiving some amount inbound from over the world. And Airlangga is also home for more than 40 nationalities of international students studying at different levels. We also welcome inbound staff and similarly send out our staff to different programs overseas. And there are more than 40 nationalities are hosted by the university in the last 3 years. And every year we have more than 200 until 300 international students studying degree and postgraduates. And last year only, Airlangga has hosted around 400 inbound staff visiting fellow, postdoc researchers, and also adjunct professor across faculties. And large percentage of staff come from Asia, and similarly, Asia also become #1 destination for our outbound staff to do various activities, including joint teaching, learning, research, and other activities. And as we move on, I would like to highlight some aspects regarding the role of Universitas Airlangga Hospital, especially related to collaborations, contributions, and also barriers, as well as the importance of medical education during the pandemic time. As I have previously explained, the UNER has number of facilities related to health, including Universitas Airlangga Teaching Hospital and also Infectious Disease Hospital. And these are two of our building facilities and that are intensively used to support of our medical educations. While UNER Hospital is considered as green area where it intend for non-COVID-19 patient treatment. And we do have UNER Hospital in this area to support COVID-19 patients. This we categorize as full negative pressure of all red area. And both of facilities are equipped with various health features. And consequently, I want to show that consequently, we identify how Universitas Airlangga could contribute better to societies during this pandemic. And we do believe that there are some issues of barriers or challenge that we face, and especially related to our functions to provide good quality educations. As pandemic is still rampant, we have our red zone, which means that this area is dangerous, and due to the nature of this dangerous area, medical students or young doctors are not allowed for temporary to interact with the patient. However, in this week, we are starting also the medical student. And however, we believe that UNER can work collaboratively with its partners, national and international, to provide various functions, including care, support, treatment, promotion, prevention, rehabilitation, as well as research related to COVID-19. And hence we created that we called of interprofessional educations and also interprofessional collaboration in health services and also interpersonal collaboration in research. And consequently, as the nature of this initiation, it is interprofessional, then altogether education and health services and also research will involve in all faculties in Universitas Airlangga. These are examples on how Universitas Airlangga works with our global partner and domestic partner and help each other. This includes university partner like Oita University, Kobe University, Flinders, Lathrop, and also industry partners and domestic institutions, including government and various hospitals. And in the core, surely various faculties of UNER working intensively with UNER Hospital, Faculty of Medicine, East Java Province Government, and also Department Dr. Sutomo Regional Hospital. To ensure our integrated approach, Universitas Airlangga ensure that there are comprehensive implementation of 3 pillars of higher education on 3 dharma comprising of education, research, and community services that is done through intensive collaboration between UNER Hospital and also faculties. And UNER Hospital also collaborate intensively with regional hospital in East Java to support interprofessional education, research, health services, and also formulating cure and therapy. Through this, we expect to be able to attract and retain talent professional. Presented here is our integrated approach on implementation of education, research, and health services in Airlangga Hospital. And UNER is considered as one of the most contributed institution actually in Indonesia with regard to COVID-19 mitigation. In our university, there are 3 teams working in IPCR related to COVID-19, and they are focusing on the vaccines, potential cure, drug, and also diagnostic. And of course, this is some of technology. We use the help of students of teaching learning where they can study remotely with 360 degrees of CCTV and with the very good quality of the picture. And also, University Airlangga works collaboratively with Technology Institute of 10 November and create the RAISA. We call RAISA is a robot that can be utilized for variety purpose. And as you can see, RAISA can be used for an isolation room, high care unit and ICU, and also disinfectant robotic has been also designed. And Universitas Airlangga also has what we call Airlangga Triage Assistant Robotic or ATAR in emergency installations. They use the ATAR to reduce SARS-CoV transmission and ensuring safety, efficiency, and effective care. And this is part of our medical education implementation. And presented here is the investigation registration system in our teaching hospital. And also, in addition, UNER Hospital already contribute through various mechanisms. Also, want to reduce the impact of COVID-19. This include international program to support UNER strategic objective, especially during COVID-19. And during the pandemic, concern about health issue have become more intense than ever. And in a way, this is actually good because everyone is certainly become more aware and caring. However, at the same time, this creates challenge, and I think in which there is no more direct interactions among people, and it eventually leads to limited physical mobility. And this requires the university to think out of the box and to innovate how university can still achieve its target despite the limitations. And in trying to cope, we are focusing on 3 pillars of education, which include research, education, and community development. And since we are focusing in coping on the era of post-COVID-19, we redirect most of our research towards the relevant study. Times of crisis also calls for innovations. And most of our existing programs have been based on credit earning and or credit transfer, and most of them are infused with cultural theme activities. With everything now converted online, we focus on improving our virtual engagement and try to find our way around virtually designed programs. And one of the earliest creative online program initiation this year is the COP, and where students participated in community development activities and had to propose an alternative to real life cases presented throughout the program. And this year, the third COP ever held and became the first online community outreach program, and that UNER had conducted under the Asia UNINET Frame Network. And before COVID-19, actually we has Bahasa Indonesia language class for students, trainings of trainer for Indonesia language lecturers for teaching in beginner level, and we even send UNER books collection. However, during post-COVID-19, we reformat our learning Bahasa Indonesia program for international students from face-to-face activities to online program, where aside from the Learning Indonesia, students can also share their knowledge on Indonesian culture and gain more insight about Indonesian culture. And we also got to conduct a webinar with international students, inviting international alumni to be a guest speaker in sharing session about study during pandemic. And some of recent webinar had also talked about global academic mobility. And we are focusing on trying to build a sustainable global academic cooperation framework. And before COVID-19, we held guest lecture series for international students talking about particular academic subject and were delivered by UNER academic. But after post-COVID, we held a series of online global classroom and delivered by UNER academics. And since everything was conducted online, we had the opportunities to explore a wider range of academic subjects albeit remotely. And such as here, we having psychology class, which talk about how to maintain mental health during a pandemic. And apart from for student-oriented programs, our educational sector also focus on trying to engage our global partners steadily through several global scholar program. And this program themselves are designed from students to be able to teach, and which we call DECOTA, or video conferencing with Universitas Airlangga program. Airlangga Global Engagement invites your distinguished scholars, including you, of course, all of here, to teach or to provide guest lecture, albeit online, and it is very convenient, of course, for you and also for us. And apart from teaching, Airlangga Global Engagement also introduced Airlangga Postdoctoral Fellowship Program, which invites academic and to conduct research activities with our prominent professor and researcher. And both DECOTA and APD here opens throughout the year and welcome any of you to participate in our program. And we are very flexible, especially during pandemic era, about your availability in Indonesia. And additionally, we are also trying to make expand our networking chains from various virtual exhibitions where we can engage with potential partners for potential collaborations. And in this year, we have participated in this virtual KSFS and KS Maple. And we are going to join KS Apple on the upcoming November 25, 2026, 2020. And we are also preparing our very first virtual exhibitions that is going to be part of our institution anniversary next month. The virtual exhibition, namely AGD, is now calling for contributor and become our partner to participate. Please join with us. And also, this is the last two slides into the integrated care paradigm, but also industry 4.0 capabilities to important as the fourth industrial revolution is transforming manufacture in line with the digital consumer revolution. So that is what Universitas Airlangga strives for as we develop a model that integrates education, research, and also health and community services. Universitas Airlangga created what we call Airlangga Health Science Institute. And this AAHCI model of Universitas Airlangga integrated program included Faculty and Center of Excellence, Airlangga Teaching Hospital, Tropical Infectious Hospital, Dental and Mouth Hospital, Institute Tropical Disease, Sutomo Teaching Hospital, and also Satellite and Network Hospital. And lastly, to include this session, conclude this session, the implementation of interprofessional educations, for example, can combine academic activities, research activities, and as well as community development in one setting and being conducted virtually. And in terms of academic activities, we have compilations as well as formulation of curriculum settings, which include elective course on interprofessional educations. In terms of research activities, we have interprofessional educations, module for social topics and on urban digitalization and pollutions. And whereas the implementation of community development activities are mostly implemented in community setting, which had been successfully implemented in all our previous program, including CU, and will continue to do soon in the future. And thank you very much. We do hope all of these supports can benefit society at large. And let's not forget that we need to continue establishing to the global academic community through the development of leading, innovative, and independent international activities like this conference. And I hope that this roundtable will bring benefits to all of us and raise our awareness and of the issues in our societies. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Professor Mitterhusser. That was beautiful, and you're to be commended on such a comprehensive program, which innovatively involves students and engages the community as well as your international collaborators. Allow me to ask Professor Charlotte Cheong to share with us. Thank you.
Thank you, Professor David Alet. Can I share my screen?
Yes, please. We see it. Yeah.
Yeah, I should probably. Well, thank you very much for allowing me to share with you our thoughts about managing relationships between medical schools and teaching hospitals. And I'd like to discuss this on the basis of our own experience. So I'd like to talk about the UP College of Medicine and the Philippine General Hospital during the COVID pandemic. As a background, the UP College of Medicine was actually founded in 1905, and it's now home to around more than 750 faculty members, about 1,000 students, 400 graduate students in about 27 graduate programs. We have 3 medical programs: the 7-year intermed program, which allows high school students to come directly if they score about top 1% in the UP College admission test. The 8 years MD PhD program that has been recently instituted about 10 years ago, and we have now about 2 to 3 batches of graduates. And the 5 years post-baccalaureate program, or what you call the lateral entrance. And we in all would be able to utilize what you call an organ system curriculum integration. On the other hand, the Philippine General Hospital is actually the country's largest training hospital, with well over 500 residents and fellows, about 575 residents and 311 fellows. We see around 600,000 outpatients, and is of course the largest training hospital in the country. It's actually a state-owned hospital. It's administered by the University of the Philippines, Manila. It's in the same campus as the UP College of Medicine. And with the new charter, it's been designated as the National University Hospital. So both the UP College of Medicine that was founded in 1905 and the Philippine General Hospital that was founded in 1907 actually predated the whole University of the Philippines system, which was established in 1908. We now we have a new moniker, which is People Giving Hope, because at the height of the COVID pandemic, when our healthcare system, especially in Manila, was already giving way and bursting at the seams, it was PGH that gave hope in terms of being considered a COVID referral center, and put some order, and we were able to at least give a lot of hope to our countrymen. Now, as you can see here, there's a dichotomy of the UP College of Medicine, and PGH has always been historically alluded to. They said that the UP College of Medicine and PGH are like Siamese twins. They're joined at the hip, but only at the back, and they face away from each other. So geographically and figuratively, one enters the other through the back door. This college the academy is considered an ivory tower, where the hospital belongs to the masses and is a lightning rod for politicians. So there have only been 3 times when, the power dynamics between the dean and director have been very rich in the history of these 2 institutions. And there have only been 3 times when a single person actually headed both institutions. One was in 1916, when the leadership transferred from the Americans to a Filipino physician, Dean and Director Fernando Calderon. Then during World War II, when the Dean Gerico Sison also acted as the director, and in fact also as the president of the university, because all institutions closed except for UPPGH. And last was during the Marcos regime. This condition has been actually improved over the past recent years under our new chancellor, Carmencita Padilla, who's actually now in her 3rd term. We've been able to move forward and progress very smoothly as a college and as a university hospital. But let's contextualize this by looking at the cases of COVID in the Philippines. We now have about well over 400,000 cases of COVID cases lodged in our national database with the Department of Health. You can see here that about 7,800 have died. And when we look at the positivity rate, we're about 5.1% now. So definitely there is a trend of these cases going down. And we also see that in the database of the hospital, where we now have currently admitted as of 15th November, 106 COVID cases. It actually reached to around 230 at the height of the surge of this pandemic. And at that point, we had to try to see and make sure that we are able to conserve our workforce. So what was initially established was, before, testing could be ramped up, where testing results could only be gotten in a matter of 4 or 5 days. We actually elected to have 30% of the workforce within the hospital, while 70% are outside on quarantine. The nearby hotels were actually used as quarantine facilities for our healthcare workers, and some of the classrooms, in fact, in the UP College of Medicine, were lent to the hospital staff, as well as some classrooms have been also modified to become convalescent plasma therapy rooms, so that, because the public who had wanted to donate plasma didn't want to go to the main hospital. So you can see here the old building. This is the UP College of Medicine when in the 1920s, and this is the PGH during the war. And what is obvious here is that whereas in the war, these two institutions were actually the only ones open, we consider this COVID-19 as like World War II again, where the cooperation and collaboration between the academic center as well as the hospital were very crucial in having an agile and very appropriate response to this pandemic. We've been able to carry on after some adjustments to remote learning, converting our in-person learning to remote learning. We've been able to actually have our students graduate. So class 2020 of UP College of Medicine actually were able to graduate, and also been able to actually take the physician licensure exams this month. We have been able to actually already ramp up the number of telehealth consultations in the hospital. This is about more than 250 now on a daily basis. And we are actually opening up our doors back for our interns on a voluntary basis, perhaps by November 26. Of course, the guidance in terms of being able to allow students or not, it depends really on higher authorities, the CHED, or the Commission on Higher Education, the Association for Philippine Medical Colleges, especially for interns. And there's a national task force, the Interagency Task Force, which is actually a conglomeration of the different ministries or departments of health, transportation, the military is involved, as well as the other, even the National Economic Development Authority and other officials of the national government. And the consensus is done in order to come up with protocols for the public. We all follow these protocols, and we also have our own protocols inside the hospital. We have not allowed our students to come back. So our medical education is completely remote, even as we started the semester last September 10, and we are due to finish this by December 18. And the second semester will probably start January 4 and end by May 31. So PGH, being a COVID referral center since March 30, was a very difficult decision, in fact, for the director when he was asked by the Ministry of Health or Secretary of Health. But once he decided with a very close crisis committee, all the faculty of the UP College of Medicine supported this. So UP College of Medicine, in fact, has helped in trying to harness also the cooperation of other partners and foundations, research groups, in order to come up with the protocols, the research studies, even with the College of Engineering at the UP Diliman, to manufacture what you call the artillery in order to fight this war. So there have been a lot of provisions for 3D printed face shields and masks, and as well as other equipment that have been developed as a result of COVID-19. What was fortuitous actually is that way back in December, we had a grant of about 190 million pesos for CBOL. Now, CBOL stands for Surgical Innovation and Biotechnology Laboratory. And as we were supposed to get the initial tranche of around 30 million pesos in March, COVID came, so this was halted. But over a weekend, CBOL actually became a CBOL versus COVID task force. And once this was convened, we could now be able to see a flurry of researches being proposed by our faculty, our trainees, and even the students. And we are very happy that the funding has now come up to around 300 million for more than 280 researches. And in terms of funding, there's actually more funding, of course, for the academic faculty, and less funding, about $400,000 for researchers based in the hospital. But the hospital remains to be the clinical laboratory, so the WHO trials are being actually conducted in the teaching hospital, the PGH, and we are now looking at the initial results of this. Now, these are some of the examples of the different projects under COVID. You can see here a telemetry station, which allowed our patients to communicate with their families. This is the RX box, which was repurposed from being a fetal monitor with an ECG and a tachometer that's usually for primary healthcare centers, have now been repurposed to be telemetry stations in the OB gynecology wards of the Philippine General Hospital, as well as in other areas of the hospital, and was very much appreciated because we can actually monitor patients remotely. We have the SunnyPad, which is actually allows our healthcare workers wearing their PPEs to be disinfected before they doff off their PPEs, and actually resulted to greater confidence that one will not get infected with COVID. So these are all the different projects. We have at least around 10 to 12 innovative projects in the College of Medicine, as well as about 10 more in the UP College of Engineering, with engineers working with our clinicians. Now, what's very fortuitous as well is that last year we embarked on what you call the digital transformation, and we wanted to create the virtual campus for the UP College of Medicine. And by June, in the height of the pandemic, we were able to launch this, where all the faculty members, all our students, and all the people who are part of the UPCM PGH community are actually able to access the memoranda. They're able to get their clearances for graduation. We have here the resources of the library. We have all the different financial management system that you can just sign off your emails and even the free apps. So very, very well appreciated, and actually gelled the community together, despite the fact that we could not be physically present to each other. It's very crucial that we are able to have this connection with each other. Our official journal is the Acta Medica Filipina, again, which is completely online, and we are able to publish most of the researches here, as well as in other Scopus Index and ISI journals. Now, this shows to you the dashboard that was created that can be accessed from the Executive Information Portal of that website, where we have about 298 researches just related to COVID alone. So you can imagine around most of the faculty are now engaged in research. We have about 360 million pesos in funding that translates to around $8 million in funding. And we can see here the graph that shows the UP College of Medicine and the PGH in terms of the absolute number of researches. But most of the PGH researchers are actually self-funded also by some of our faculty members. So we dealt with diagnostics, clinical features of the disease, researches on treatment, researches on psychosocial aspects, mental health. There were researches that looked at traditional medicines like virgin coconut oil, lagundi, and for the treatment of COVID, and some other cocktails that have been proposed by other entities are being looked at by our scientists and researchers in the university. What was also very crucial is the fact that we were able to harness technology in order to improve on our pedagogy. We have been able to, wanted to actually aim for 30% intake of our virtual learning environment or platforms when we were accredited by the AUNQA in August 2018, when they found that our utility rate for our virtual learning environment was only 8%. So we wanted to increase it to 30%. Target was supposedly by last month, but when COVID came, actually it increased to 100% because of the pandemic. We also invested last year in a video lab capture for lectures, the Panopto platform, which has now been used as well by the different clinical departments for their postgraduate courses, for recording their lectures, for asynchronous access by our students. As we had 2 typhoons recently, we had to make sure that our students are not disenfranchised, and we were able to ensure that course packs were actually sent to them at the start of the semester, so that even if electricity is down or calamities come in, or with sudden surge again of infection, they should be able to still access their courses and we'll be able to assess them even asynchronously. So we now have the 2 virtual learning environment, the Moodle base as well as the Canvas platform. I think in the audience is our Dean of the College of Allied Medical Professions, Dr. Dean Marily Aguila, who's our main champion for the Canvas learning platform in the University of the Philippines, Manila. So we've been able to graduate our last batch of medical students, Hiraya, what you call the legendary batch, because they've been very resilient during COVID. In fact, we were so happy that when the national government actually declared a moratorium and disallowing them to go to the hospital, within 24 hours, about 130 of them actually volunteered to stay on and to serve the patients of PGH. So we've been able to actually assign them to the call center, to the telehealth centers for teleconsultations. Some were in the designing of infographics for the public dissemination of information, as well as the donations arm, trying to see how we can an organized way of being able to accept the donations that actually poured in when PGH was actually considered as a COVID referral center. There's a lot of media attention, and the frontliners were very much appreciated by the public. So we had a lot of goodwill, and I think for the first time, the public has really focused on healthcare workers and their plight, which we would like to actually harness. So we've been able to mobilize our alumni to donate. For example, here, the 3 virtual dissecting tables for anatomy, which is now being used for synchronous lessons in anatomy. And we also invested in some visualizers, because now the prosection of the soft theal human cadavers or silent mentors will be done by our faculty and beamed to the students. As although we would like them to come back by January, we're still not sure. We're still trying to draft the guidelines for safe return of our students by the 2nd semester of this academic year, starting January. As regards the learning assessments, we had to, of course, consider that our faculty had to divide themselves. Some of the younger faculty actually were the ones driving the clinical services in the hospital. Some of the senior faculty focused on being able to take care of the students and give the synchronous lessons for our students. Whereas in the middle, we have all the other faculty who've been trying to shuttle back from being clinician for clinician services as well as for medical education. So it's been a lot of cooperation in the different departments. We look at the way we have delivered our medical education by doing a survey about a month after we opened this semester. And there's been an assessment that for remote learning, according to the faculty, it's actually a very good experience. And the students also rated our remote learning environment as good to very good, which we are happy about. But there are still a lot of concerns, like we realized 30% of our students actually had no laptops or gadgets. And so they had to acquire this. But since 30% of them actually had come from very poor families, we had to make sure that we are able to provide them the laptops that they needed. We even supported the mobile loads of 149 of our students so that they can still get connected and be able to attend some of their synchronous lessons and download their materials. But the main observation is that we still have to be able to balance this, because our faculty are very intense in giving these reading assignments, so that our students have been complaining that perhaps they should be concerned about the time that it will take to be able for them to complete their task. So this is the time to task for the requirements of the different year levels of our students. So partnering with alumni and friends has been very gratifying during the pandemic. We've been able to get millions of pesos worth of PPEs for our healthcare workers. In the initial phase, we got some donations from the Temasek Foundation of Singapore with 20,000 A-Star kits. As we were, at that time, we were developing our own RT-PCR kit and was undergoing validation. This came in very, very handy because we were confident that we'd at least be able to test our healthcare workers in the hospital should they need them. We've been able to get automated PCR machines, freezers for samples, the laptops, as well as now with the recent typhoon. I just launched a Pantawid scholarship program to aid some of our poor students whose homes were devastated by the typhoon. So we're trying to raise at least around $500,000 just to be able to support them. So aside from this, we have a limited amount of simulation right now, which we would like to improve. And we've been able to lodge with the Philippine Congress a proposal for the country's largest clinical simulation center that can be housed in the 6th floor of this medical sciences building. It's under construction right now, and we hope to be able to finish this by the first quarter of 2022. We're now on the 5th floor of construction, so we're confident that it will be finished. We would like to ensure patient safety and be able to use simulation in order to comprehensively develop clinical skills among our trainees and our students as part of our mandate to be able to provide them the best medical education. Now, what perhaps I would like to say is that this collaboration and cooperation, the calibration of power dynamics that could sometimes be problematic, were managed very well because the director of the hospital, as you can see here during the graduation ceremony about 2 years ago, Director Dr. Gerardo de Gaspi is actually a neurosurgeon. And I'm a neuro-otology surgeon, and we've been working together since 1993 when I came back from my training. So this is the two of us doing skull-based surgery on acoustic neuroma patient just about 10 days ago. So we are able to banter and communicate very well with respect to what could be beneficial for both institutions, both the hospital and the college. In terms of plantilla positions and career tracks, these have been smoothened out in the past several years when both of us, so leadership and the cooperation between leaders, I think, forms the basis for having a more robust engagement when it comes to medical education in a setting where the university hospital is actually staffed by academic faculty. So with that, I'd like to end my talk. I hope I've been able to inform you about how we have managed the relationship between the UP College of Medicine and the Philippine General Hospital, especially in the era of the pandemic. And I am really actually very confident that with this type of collaboration during these extraordinary times, we will be able to serve our institutional missions even more. As we have been able to do it in ordinary times, we should be able to do it even better during these extraordinary times that we are in, which is really just, I think, a surreal interlude that too shall pass. Thank you very much.
Great. Thank you, Dean. And thank you to all the panelists for their wonderful presentations. We're all better for it and have a greater understanding of what has been done and what can be done. As a reminder to our audience, please use the Q&A feature at the bottom of your screen. We do have some questions already. Time is short. Some of our folks on the panel will need to leave. So if you would, I'll begin. I'll forego my moderator's prerogative and just jump in. This is from Hario Bismantara to everybody. Would you please, would the speakers please comment, what are the keys to initiate academic health collaboration in responding to emergency situations like COVID-19? And how do you ensure that this collaboration will have positive impacts, not just to the university and to the teaching facility, but also to the community? And I'll just ask my, panel, just feel free, jump in and run. Yes, please.
I think the communication is very important. And in essence, the social media Viber chat groups were implemented. And so it's very easy for the different leaders of the different departments and for the crisis management committee of the hospital, as well as the academic faculty, to be in touch with each other in order for us to be able to balance out the different needs and priorities of the hospital in terms of pandemic response. So I think that the projects that would allow the teaching hospital to be able to deliver the care that it should be able to deliver during this pandemic is something that is considered to be top priority. But we also know that for us to be able to do that, infection control within the hospital is very important. And so therefore, departments will have to help out each other. So there was actually redeployment of some of our resident trainees in the different specialties to be able to help the internal medicine the residents and trainees. So for about 10 months now, some of our residents in ORL are still rotating in the medicine wards. And we feel that that's still education in terms of being able to come up with a good response to pandemic. And it's like the World War II, which also had the same arrangement where you actually have the deployment of the different resident trainees. So it will certainly delay some of their graduation because the accrediting boards for the specialties will have to define what will be allowed in a pandemic like this in terms of experiential experiences or actual hands-on experience or clinical care for specialties. And we are very well aware of that.
One more thing, if I may jump in here.
Please.
In CAR, we also same thing happened, obviously, if, as far as the other residency from other specialties pitched in and helped with redeployed to field hospitals. And also, in addition to that, we also, our residents and our students were very, very active in health advocacy around educating the public around social distancing, educating them around COVID-19 in general, the mechanism, the way to avoid it, the way to handle it, and so on and so forth. As you can imagine, the social media was pretty much bombarded with a lot of rumors, a lot of misinformation, and our students, our residents, fellows, and even faculty were all very active in trying to basically bust those rumors and sort of educate the communities around them around the best way forward, what is fact, what is fake, and so on and so forth. So that participation in the community is critical when it comes to something like COVID-19. It's not just to be the recipient of patients who are sick with COVID-19 who need hospitalization. It's more than that. More than 90% of patients do not really need ICUs. And therefore, we need to be out there in the community, and our residents and fellows and students were out there. And the other thing is there was very close collaboration with the Qatar Medical Society, who was also a good platform for all the healthcare providers to be there for those sort of different types of roles that they needed to play. So they need to be also trained on how to be an educator, how to be a communicator with the community, how to advocate, and so on. So a lot of physicians are used to hospital environments and being there in the treating seat, not in the educator seat. So that was also a learning experience, and the Qatar Medical Society provided the platform also that teach the teachers sort of a platform as well. So some of the nurse educators were brought in to teach our physicians and students how to educate the community, how to go and advocate for the right things to be handled during the COVID-19. So
thanks, Professor Nakanjako. Oh, sorry, Professor Miftah Husser, go ahead, please.
Yes, thank you very much. I think
Yes,
for the first question about how the collaboration in responding to the emergency situation like COVID-19 is, I think the two keys. The first is how we create the online programs, and also the second key is the consortium. With when we make both of the two programs, we believe that by participating in such activities, we are able to contribute on the community by discussing some specific issues raising in the community at the moment, equipped with target activities and outcomes. And for example, we have a Dekota or video conferencing with Universitas Airlangga program, and in this program, all of the research that connected with us, including all the foreigners, they can arrange all the specific theme about what they want to share with our communities, including all of the non-health patient, I mean subject, I mean the patient or something. We usually also make a special program also for non-medical person. And also, for example, we also very actively join with consortium. I think including this forum also like a consortium. Within in international level consortium, our active partnership are comprised of more than 200 partnership globally. And with consortium, Universitas Airlangga is involved in several collaborations. This one including joint research, student lecturer, and also staff exchange. With this consortium, and if we make a very active consortium, we can do many other things, many other forms of mutual collaborations, I think. And for the second questions, I think for the how to light what kind of staph COVID exposure, actually, since we are dealing with the unfamiliar situations, it requires specific treatment. And especially now, the vaccine 19 is not yet been found effectively. I think we are working to create safe environment for both of the patients, also medical staff. Although this month we are starting the medical student, however, unfortunately, we detected 3 students infected. So we, after running 2 weeks, we decided to stop first and then try to make sure everything okay for especially patient that we already the priority. And of course, recently we all the medical staff to avoid unnecessary contact with all the infected one and the reduced number of infected individual virus from the virus. On the top of that, we also implemented really strict protocol in preventing the wider spread of the virus. And therefore, with the collaboration with our neighbor institute, Technology School November University, we make several robots. This prevent all the, including medical staff, to contact frequently. With this way, actually, we maybe only the nurse only contact 1 or 2 times a day. With this way, also the medical staff we expected reduce the infection to our medical staff and also medical students. Thank you very much.
Thank you. Professor Nakanjako, your thoughts about keys to initiating academic and health care collaboration and responding to emergency situations like COVID-19, and how to ensure engagement with the community? Oh, you're muted, Prof. You're muted, sorry.
Sorry. Thank you. My thoughts on this is that collaboration is very important and it needs to be multidisciplinary because of the interdisciplinary approach that is required for COVID-19. Not only for clinicians, and even among clinicians, it involves nurses, different units, ICUs, pulmonary units, research units. So it is an interdisciplinary approach. And at a broader level, it includes economists, manufacturers of things and equipment and drugs, and pharmaceutical companies, policymakers, IT infrastructure. So it is really a broad collaboration that needs national involvement and coordination with a very strategic communication. And we also need international partners because this is a global problem. It affects travel, it affects the way airports are running in different countries. So we really need interdisciplinary and multi-country collaboration. Unfortunately, this actually exposed a lot of inequalities that are available in the different countries. So different countries have different responses, and this is an opportunity to really look at our global approach to epidemics, because at the end of the day, all the countries are affected. Thank you.
Yes, thank you. Allow me just to speak momentarily about one of the aspects that was raised, and that was involving our non-infectious disease, non-internal medicine brothers and sisters. It was really eye-opening. I think there was an initial anxiety and hesitance on their part. And then when they became immersed in the process of helping out, they actually very much enjoyed it. It got them back to their roots. They learned something. They felt they were making a significant contribution, which they were. And I think it helped narrow that divide that sometimes exists in our medical subspecialties. So it was great, and they became great advocates as far as educating the public as well. So it was really a very useful multi-pronged tool. Professor Mifta Husar has already addressed this a little bit, but if the rest of you would speak to the second question about staff exposures, what they've been like, and how do you protect or financially protect the healthcare workers that may have been involved in, and their secondary outcomes in their families, or secondary infections in their families.
So if I may, because I need to go to the clinic, they have been calling me, so I'm just gonna give you the my intake on this one before I leave. So here at Sidra, what we came up with what we call COVID-19 vacation or COVID-19 off time. It's up to 2 weeks. You had the right to be completely fully off with full pay for up to 2 weeks if you got exposed or you had to be quarantined, if you had the infection or you got exposed and you had to be quarantined. So that's one thing. The other thing is that the workforce working from home, if you didn't need to be here physically, more than 80% of the work could be done at home and you get fully paid as if you are in campus. So from the HR perspective, they were a bit, well, they were rather flexible to be able to accommodate people not needing, who do not need to be here. They shouldn't be here. So they shouldn't be worried about their pay, because otherwise, if you don't have to be here and they come here because they want to be paid because of that, they could be exposed or expose others. So that was a very good way of avoiding unnecessary exposure to the staff. And if you allow me, I really need to go to the clinic. So my apologies for keep pushing.
No, thank you for joining us. We very much appreciate it.
Thank you.
Dean Chiang, healthcare worker exposures and how to protect them. Yeah.
Yeah, well, as shown in one of my slides, we actually tested more than 10,000 healthcare workers in the hospital. And we actually categorized them as working in the COVID or the non-COVID wards. And what we found was that there's a 4-to-1, meaning to say we had more infections in the non-COVID wards compared to the COVID wards. Now, the national government has already passed the Bayanihan law, which actually gives full coverage and full coverage in terms of financial support when you are a healthcare worker that contracts COVID as part of your work. So that has given a lot of assurance to our healthcare workers that they will not be very much at risk financially should they contract the COVID and require hospitalization. We also are actually telling our interns who presumably are not really employed by the hospital but are actually considered to be volunteer in terms of healthcare services that they will also be fully covered should they get infection as part of their return back to the hospital. So even while we have been able to really effectively put controls for infection control in the hospital, which you will hear about tomorrow, the infection control head of my hospital, Dr. Nina Berba, will be giving her talk tomorrow about what we did at the UPPGH. We are quite confident that we've been able to put the necessary structure by which they will feel assured that there will be no financial calamity in terms of being infected with COVID.
Great. Thanks for sharing. Prof. Nakanjako, how have you all addressed that issue?
Thank you. I think like many have mentioned, we have had interventions for reducing exposure to our workers by having them work in shifts so that we have at least half the people work for 2 weeks and half the people work for another 2 weeks to safeguard so that if one shift gets an infection, at least we can have them go off and we have another shift come to take over. And we've really encouraged those who don't have to come to hospital to work at home and limit the interaction for only when they have to see patients. And we have also incorporated screening of health workers as part of daily routine for that, as well as supporting the care of the patients, of the health workers that are found to be infected. But I must say that we've had maybe less than 2% of our health workers get infected. I think we've also had to benefit from the previous experiences that our country has had handling Ebola epidemic and Marburg epidemic. So this found us a little bit more prepared with response teams and training of health workers on how to handle these epidemics.
Great, thank you. Prof. Mifta Husser, do you have anything else to add to your earlier
Enough,
comments?
I think, Professor Allen. Enough.
Okay, great. Let me ask a couple of questions that I'm interested in. We don't have time for many, and I know all of you have other places to be, but I'm just curious, you're all leaders in your institutions, and I know our governments have been extremely generous and supportive of our efforts with emergency funding and every other support they can give. I'm just wondering how you're thinking about future financing of your academic medical center. Certainly because of economic downturn, there's going to be belt tightening in every sector. I'm just curious as how you see that future. Dean Xiong?
Well, certainly we note that we are now in recession here in the Philippines. We have our unemployment rate is double digits now as compared to pre-COVID. We have a lot of our countrymen who are suffering, and the government has already given what you call aids for them. It's a whole of society approach. We have actually, as part of the university, we came up with a position paper telling government that we cannot just focus on the hospital services, but we need to be able to support the communities at large, and that we were telling them that this war against COVID does not happen in the hospital, which is the last stop, but actually should be in the community where borders of families should be protected, and economically they should be able to be supported so that they don't have to go out and look for work or look for food. And I think our government has been good at this. The initial response was very slow, but they've been able to do it. As we look forward, there are now a little bit of economic activity coming on since about maybe 2 months ago. Our manufacturing, I think, has already increased. The economic authorities are telling us that even though it might take a while before we reach the former levels of growth that we have in our country, that we should be expecting to grow by next year once the vaccine is here and we're able to resume our economic activities in the country. In the Congress, because we're now in the middle of budget hearings, actually, I think we'll be getting the university hospital, we'll be getting the largest ever budget support. I think we're looking about 6 billion pesos, which is actually double than what it was about 6 years ago. So I think we'll be able to even improve the services in the hospital, modernize even, and maybe expand even our services so that we're able to have the same DNA of the Philippine General Hospital, not only here in Central Luzon, where we are now, but actually the government is smiling of setting up the similar academic healthcare center facility in Mindanao, which is the southernmost island, and also in the Visayas. So we're looking at expanding even. So that's the silver lining. I think what this pandemic has done is that it actually galvanized the support for health in my country. I think there's now more impetus for our politicians to look at healthcare as a very important aspect of being able to serve the population and make sure that and now they realize that economy is not really opposite health. In fact, health is economy. So they have to be able to protect the population in order for economic activity to again grow, and that has now been realized. So the opposition between opening up the economy and health has been a raging controversy initially, but when they realized that the foundation for economic growth really is a healthy population, I think we've been able to make inroads.
Great, thank you so much. Professor Miftahusur, how are things in Indonesia?
Thank you very much. Of course, about financial planning, we have a really trouble, especially in research area. Although we got several grants from our government, actually, in the fact after COVID-19, it reduced almost 50% of the grant we can receive. And in addition, in our university also, some of the grant, although in the similar number, but they also give a sign to us about probably will be reduced in 2021. And how to manage it? Actually, during pandemic, of course, we reduce more the wet lab, actually, and we try to make some try to writing a review paper, systematic review, or meta-analysis to move a moment. And in addition, we also try to focus on the problem solving of the pandemic. We only recently, all of our research only focus of 3 things. One is the vaccines. So we have 3 big teams about the vaccines, 3 different vaccines. And also we try to join with several groups for the vaccine trial as for example, this week we starting from Oxford University vaccine. And also the second one, we try to find the potential drug for new drug, and we collaboration with the 3 company, pharmaceutical company. Of course, with this way, we have we try to find a way for the more budget. And also the last is about diagnostic. We this month is a trial to our new fast diagnostic for COVID-19. We believe the COVID-19 will not finish soon. I think probably in the end of 2020. This is the really optimistic. Try to optimistic in the end 2020. But however, we believe that although we have a vaccines, but the diagnostic is most I mean the related with the cost of the health. Of course, I think the fast diagnostic is the most important also in this side of the vaccines. And for the education, recently 2021, just this week we have the meeting with the rector, and I become one of the vice rector, also try to combine online and offline. It's for the reduce of the budget, especially for education. And also we have the one of the option is the about postdoctoral degree. Postdoctoral degree previously we mandatory, they of course they have to stay in Indonesia. However, now we reduce the 50% of the budget for a postdoctoral degree, and they can stay in their country. But we have also a target for them and what they do and what we want and something. And also we have a new program we call is the adjunct research. Adjunct research program, it's mean you have not, because adjunct professor need a special requirement, but we have wants to still make a collaboration with the abroad. So we have like adjunct research. In this program, we thought the requirement all the abroad researcher can join with us, and we can ask them what they want, and we can prepare matching grant, including a special lecturer, or making many webinar for them. So the collaboration with another institution and still actually still maintain our rank actually to maintain our rank with the collaboration with other universities still still
all right.
maintains. Thank you.
Yes, sir. Thank you, Prof. Prof. Nakanjako, how are things being impacted in the future? Maybe not right now, but in the future. Oh, your mute is on.
Thank you. And with financing, I don't think that we have all the solutions now, but we are continuing to look for innovations. But certainly there's an impact on the economy in general as a country, especially for a country that has a lot of imports. But we have also seen that this is the time now to concentrate on production locally, what can be produced locally in terms of education materials, and medical equipment and facilities, so that we can reduce the cost of production to do some savings. But we have also received government funding to support particular research and transition of education to online platforms. But also our researchers are actively applying and winning grants from international grants from Europe, USA, and other funders that are available to fund research in this area. And as I mentioned earlier, we have looked at public-private partnerships, private businesses, to be able to support the government enterprises to go through these funding difficulties. But in general, we think that having a limited number of deaths puts us in a great position to recover, because for looking at the previous experience of the Spanish fever, when you return, it's the people that have managed to stay alive that will be able to pick up in the next time after the epidemic. So we think that if we concentrate on minimizing the number of deaths, we should be able to put our country and the setting in a better position to recover after the pandemic.
Great, thank you so much. There's so many other questions I'd like to ask about how do you measure the competence and knowledge base of the students you're graduating under these rather dire circumstances, and making sure we maintain high quality, and how you deal with issues of connectivity with regard to the internet for everybody in whatever remote places they may be. But we don't have time for those questions, and I'm sorry for that. I do want to just mention that I think we've learned a lot about collaboration and coordination of effort and innovation. The ability that COVID, actually one of the silver linings is get us to focus, to work together with the common purpose. flexibility to deal with the barriers that have been before us, and ultimately self-reliance. I think we've all learned that the world is a complicated place, and we can't always depend on those we've depended on in the past. So we need to be able to figure it out, and through collaborations like this, we can work together. So again, thank you to our speakers. There is a chat box with the full agenda that is, there's a link there. And join us tomorrow for the following sessions: current practices in population health at the Academic Health Center, COVID-19 treatment and vaccine development, and finally, preparing academic health centers for the future. Thank you again for joining us today, and have a lovely rest of the day. Bye-bye.
It's a pleasure.
Thank you very much.
Bye-bye.
See you all.
Thank
See
you
you
very
all.
Bye.
Thank you.
Bye.
Nice to meet you all.
Nice to meet you too, and bye-bye.
Bye-bye.